Good morning, everyone. Good morning, good afternoon, good evening. It's morning here in Toronto time. I'm Dr. Peng, a Vitreoretinal surgeon and assistant professor here at University of Toronto. Thanks everyone for joining us, and hopefully I'll be able to share with you all a practical approach to the interpretation of macular OCT, which is something I do on a daily basis. I have no financial disclosure related to this topic, but I do like to thanks to Cybersight, Orbis, and Lawrence for inviting me for this opportunity. And I do want to bring your attention to those who are interested in learning more about OCT cases. This is a website that my colleagues and I put together, and it features many of the OCTs, including retina, glaucoma, neurals, and hopefully eventually cornea, and OCT angiography. It's a free virtual platform that we hope to spread around the world. And in return, all we ask is for those of you who enjoy the website to contribute your cases. So then we can actually bring more cases to audience around the world. The objective of today's education is to appreciate the advancements of optical coherence tomography technology and how dependent we are on a day-to-day basis, especially for a busy retina clinic, and be able to identify normal, and therefore in order to diagnose the pathology. And also, as we all know, not all the times we know the diagnosis. So therefore be able to interpret retina OCT and isolate the location of pathology often will help you narrow down your diagnosis or differential diagnosis. And of course, to appreciate some of the updated macular OCT signs. I know some people express interest in learning the interpretation of optic nerve, and those should also be uploaded later on OCT cases for those who are interested. Now, we have to pay respect to those of our predecessors who developed the OCT in 1991. Now, we can see how far we have gone from the images that initially published in 1991 to the image that we're able to get today, which are fast in office and without dilating the patients often. We're able to see almost live retinal pathology. And hopefully with advancement of the technology, we're able to see more of a cellular level. We already are able to explore the choroid, right, with the advancement of enhanced depth OCT and also OCT angiography. I know a lot of people express interest in learning this, but so I added a few slides on this talk as well for today's presentation. A really quick word about obtaining OCT images in your busy practice. The first thing you do is to make sure the quality of the image, the name of the patient, the eye with the unilaterality of the eye, the date of acquisition, and before you proceed, so you know you have the right patient, the right eye, and the right date. Often the picture you presented might not be the right slide. For example, in this case, patient presented with vitreomacular retraction with disturbance of the outer retina, presenting as an impending hole or stage 1B hole based on Dr. gas. However, for those who are astute, if you look at slide number 4, there's already formation of this macular hole. So it's important to scrutinize the slides that we have. And if you have actual machine with you or the forum where you can scroll up and down the slide, that would be great. And some people mentioned the different scanning patterns, and that's also very important in determining what you want to do. A single line for a rapid scanning of the macula or area of interest, and radio lines for determining a source of pathology that you're trying to discover. And the 5-line raster, usually what I use for macula. Now, in order to diagnose pathology, we have to know the normal. And these are readily available online and on our OCT cases, where you first should understand what the normal retina looks like and how the different layers present itself, and what are the cellular components. And that will help you isolate disease pathology and why certain diseases happen. So let's start with a warm-up quiz, and then we'll have a post-lecture quiz. So question number 1 is, which of the following image is a pseudo-hole? And if we can launch a poll, that would be great. That is great. All right, and question number 2. Which of the following contains retinal schisis? And what findings are present on this particular OCT? Is it 1, vitreomacular traction, presence of epiretinal membrane, presence of retinal schisis or foveal schisis, or macular edema with presence of intraretinal fluid? Or can this be a combination of 1, 2, 3? Or is it all of the above? Excellent. And moving on to the next one. Which of the following is reticular pseudodrusen? Now, we all see drusen on a daily basis, and this is a bread and butter of retina clinic or even general ophthalmology clinic. Now, with the advancement of the technology that we have access today, we should be able to differentiate various types of drusen that get associated with implication. Right? Even distribution amongst the answers. And finally, what is the diagnosis of this? And also think to yourself how you would describe this OCT finding. And as we're doing the poll, I just want to bring everyone's attention to the fact that as an ophthalmologist or eye care professional, we're very privileged to have access to the various imaging modalities and making us almost our own radiologists. We don't have just access to OCT, we have OCT angiography, fluorescein angiography, ICG, optos, autofluorescence, speed scan, A-scan, and various imaging modalities. So it is really fun and a good time to practice medicine for the eye. So yeah, this is great. Also distributed between 1, 2, and 3. So we'll go through all these questions throughout the presentation, and then we'll do this again. So for the purpose of my talk, I would like to divide the OCT interpretation into 5 different zones, and I'll tell you why. Zone number 1 is the vitreous cavity. Zone number 2 is epiretinal or vitreoretinal interface. Zone number 3 is intraretinal, which is further divided into your inner retina, outer retina. Then we have our subretinal space, and followed by the choroid, which with advancement of imaging, we're able to explore a lot more. The vitreous cavity is probably the easiest of all the zones because we don't really need OCT for this. And there's only a handful of conditions that has a vitreous cavity here. The vitreous is made of 99% water and therefore should be optically transparent. The only reflection we should see are the posterior hyaloid. Now, when we do see something in the vitreous, and someone mentioned this in the pre-lecture question, that how do you know something is artifact? Now, in this case, we see these hyper-reflective material in the vitreous cavity. Now, how do you know this is not artifact? You look for a transmission defect. So if these are truly in the vitreous, then the light that it transmits should not pass through. As you see in the red arrow. And if you can see my cursor, my mouse here, you will see this sort of light blocking transmission defect, signaling that these are truly present in the vitreous, obstructing light, hence casting this shadow on the retina. And so what can this be? These are large refractile bodies in the vitreous cavity. We can all see this in the case of osteoporosis. Here we have another case of something in the vitreous cavity, presence with hyper-reflective dots, and also this hyper-reflective band, which is somewhat associated with the posterior hyaloid, which has lifted off from the surface of the retina. At the same time, we see these little deposits on the surface of the macula as well. So you know these are not artifacts, and they are truly present, not far off from the surface of the body. One of the questions that we commonly ask is, if you see the posterior hyaloid, say, within the scan of your OCT image, will you call this a PBD? Of course, the answer is no, because PBD is defined by the liftoff of your Weiss ring. And in the image of OCT, often the distance, even the thickness of the retina, is about 250, 300 microns. And so this distance between the hyaloid and macula is very, very narrow or small. And therefore, usually the detachment does not occur with it. And in this case, you have subhyaloid hemorrhage in a patient with proliferative diabetic retinopathy warranted surgical intervention. And finally, the last thing that's very common we see in the vitreous cavity are these hyperreflective foci, just like we saw for the red blood cells. In this case, is associated with this fluffy deposit on the surface of the retina. And these are usually associated with vitritis in the case of an fungal endophthalmitis. And that's it. The pre-retinal zone is covered. And we move on into the epiretinal or vitreoretinal interface, a zone most interested for most retina staff, and surgical retina especially. Most of the vitreomacular interface pathology are a result of posterior hyaloid detachment. For example, we have vitreomacular adhesion, or the detachment of posterior hyaloid from the retina surface. When there's a tight adhesion, it often results in vitreomacular traction. And with sufficient traction, it can lead to macular hole. And epiretinal membrane, in the context of PVD, are usually result from a somewhat traumatic vitreous detachment, leaving little micro abrasions over the internal limiting membrane. We all know that internal limiting membrane are the foot processes of Miller cells. So when these internal limiting membrane gets a little disrupted, we can get hyperproliferation of glial cells and Miller cells and proliferation of epiretinal membrane, where there's sufficient traction, and also lead to schisis and detachment. Everything we discuss will be in accordance to the 2013 International Vitreomacular Traction Study. And so that way we keep everything consistent and uniform. The first pathology is vitreomacular adhesion, and this is the parafoveal hyaloid detachment without disturbing the architecture of the macula. And of course, for any vitreomacular traction adhesion, we define by the width of its attachment, either focal or broad, which is more than 15 microns. And the red arrow shows the reflection of the posterior hyaloid with attachment to the fovea with preserved foveal depression. Now, foveal vitreomacular traction leads to a more tighter adhesion over the fovea, and as the posterior hyaloid lift off with the process of posterior vitreous detachment, you will see either presence of intraretinal fluid or schisis, and of course, with sufficient traction, it leads to full thickness macular hole. Of course, posterior hyaloid detachment is not equal to posterior vitreous detachment, which we discussed earlier, requires clinical diagnosis of presence of a noise ring, because that's where one of the tight adhesions of the vitreous with the optic nerve head. And so how do we describe these on OCT? So every time we present with OCT, we review these like a radiologist. We will look at the vitreous cavity is optically empty, presence of the hyaloid and vitreomacular traction, leading to blunted foveal depression, or in this case, a thickening of the foveal depression, presence of intraretinal cystic cavity, and also disturbance of the outer retina involving the ellipsoid layer, which we'll talk about shortly. Now, you can see this red-yellow arrow point to an inward bending or bowing of the outer retina, secondary to an inward force of attraction pulling the retina vitreomacular complex inward. And this is a sign called the cotton ball sign, and usually is a good prognosis. Sometimes after spontaneous release of vitreomacular traction, surgical or spontaneous, or even in presence of epiretinal membrane, despite complete resolution, you can still get this residual cotton ball sign. And sometimes we mistaken these for either pseudovitelliform dystrophy or for CSR or for Best disease. You can actually see these as a residual post-vitreomacular traction, and with time these can resolve. In this picture, we also see presence of epiretinal membrane. In a recent publication, the rate of spontaneous release of vitreomacular traction is less likely with the presence of an epiretinal membrane. Here's another case of a vitreomacular traction syndrome with presence of vitreomacular traction, resulting in the development of a thickness macular hole and subretinal fluid with foveal detachment. and also your presence of these hyperreflective dots in the vitreous, in the subretinal space. These are most likely from chronic detachment or RPE cells. So what about this image? This is an image of the left eye. So to tell the left and the right eye, we often look for the nerve fiber layer sign. So usually, the green arrow indicates a thickening of the retinal nerve fiber layer, which is usually next adjacent to the optic nerve head. So this is an image of the macula of the left eye. And we can see the vitreous cavity is clear. And at the surface of the retina, we see this retinal membrane, which is presented as a thin hyperreflective layer, causing contraction and thickening of the retina. And that's labeled by the yellow arrow. Loss of the foveal contour. We don't see the foveal depression in the foveal pit. And also, we see that the inner retina layers are uniformly distributed. And as we all know, in the fovea region, we shouldn't see all these inner retina layers. Therefore, there's something called the topic inner retina layer. And this is important for epiretinal membrane staging, especially for surgical retinal specialists. In addition to vision itself, the staging of epiretinal membrane also plays a role. In this case, picture number 3, we can also see presence of schizophrenia. So the staging of epiretinal membrane is number 1, presence of epiretinal membrane labeled by the orange arrow with preserved macular contour with foveal depression. Stage 2 is is basically stage 1 with blunting or thickening or loss of foveal depression. Stage 3 is your epiretinal membrane, thickening of the fovea. And also you can see the red arrow points to the inner retinal layers being drawn towards the fovea. And of course, then this basically brings it to ectopic inner retinal layer. And stage 4 will be stage 3, but with disorganization. However, for surgical retina in the treatment of epiretinal membrane, I still base it more on patient symptoms. However, outcomes have been shown in previous studies for stage 2 to stage 3. Beyond stage 3 to stage 4, the outcome is less favorable than those with earlier staging because of this disruption and the changing architecture of the retinal surface throughout the retinal structure. One of the OCT modalities not commonly used is the retina thickness map. So this is also very helpful in determining surgical planning. Especially in this case, you can see areas of epiretinal membrane, and you can, based on this, to decide where to initiate your membrane peel procedure. So what about this condition, which is clearly associated with epiretinal membrane? We see that the vitreous cavity is normal, and the orange arrow indicates the presence of epiretinal membrane. The blue arrow is indicating that the outer retina is preserved. Therefore, this is not a macular hole despite appearance. Macular this photo appears like a macular hole. So we call this pseudo hole. But what are its features? The features is that its foveal depression is very exaggerated. And you can see that the edge of the macular foveal depression is straight and smooth, almost like someone standing on the side of a cliff. And this is a condition called a pseudohole. So here's pictures of 3 pseudoholes. They're usually associated with epiretinal membrane, and the edge of the pseudoholes are usually straight. And as you can imagine, like someone standing on the side of a cliff, you can jump off the cliff, and therefore that's a pseudomacular hole. These are amenable to surgery, although most of the time they're very stable with vision between 40 and 60, and interventions warranted if the patient's symptomatic or there's progression. What about this particular case? Also look like a pseudohole, doesn't it? But what's different is that the edge of this depression seemed to be chipped, almost like someone took a bite into it. And the ultra retina is intact. So therefore, this is not a macular hole, it's a thickness macular hole. The shape of this sort of chip region, intraretinally, it's the shape of an anvil. And therefore, this is what we call a lamellar hole. Associated with a lamellar hole is usually pretty stable vision. And it's believed to be a derived of a retinal cyst. We can imagine previously there's a cyst, and if it's derived, then you get this sort of structure. It's usually surgery is not warranted, and vision, as you can imagine, there's a missing piece, and you can't really put this back together. However, surgery is warranted in each progression, especially to convert the full thickness back in the hole. In this image, you also see presence of internal contraction and this structure, hyperreflectivity on the surface of the retina. As you can see on my cursor here, I'm not sure if you can all see this, but the green arrow labels this sort of membrane on the surface of the retina. This is distinctly different than epiretinal membrane, and it is called the epiretinal proliferation associated with the lamellar hole. And what this means is that the contractile element, as we see in epiretinal membrane, is not the same as this epiretinal proliferation. This membrane does not contract, and therefore most lamellar holes are stable over time. If you've ever done surgery for these sort of lamellar hole related to epiretinal proliferation, these late membranes are very sticky and they appear yellowish in consistency, but distinctly different. So when we present cases, we differentiate epiretinal membrane and epiretinal proliferation associated with lamellar hole. So now we look at the different images, we should be able to differentiate between epiretinal and lamellar hole. So in the picture number 1, we see this sort of straight edge, like if you're standing on the side of a cliff. This is a pseudomacular hole. Picture number 2, we see this anvil sign associated with this hyperreflective membrane that's very smooth without any corrugation. Therefore means there's no contractile force, and that's the lamellar hole associated epiretinal proliferation. Similarly, with picture number 3, a lamellar defect with the part of the retina being chipped away. And number 4, we have pseudohole with corrugation of the retinal surface, indicating presence of the epiretinal membrane, and also straight foveal edge. So sometimes lamellar hole, although rare, can convert to a full thickness hole, as we will see in this case. This case has a lamellar defect with intact outer retina, presence of epiretinal proliferation. And as we follow this case, you can sort of faintly see what we call a subfoveal stress line. And for those who are interested, you can always look this up. A subfoveal stress line usually can potentiate a sort of impending macular hole to a full thickness macular hole. It's usually right in the middle of the fovea. You can see this sort of very faint subfoveal stress line. And of course, case open up, you have a full thickness macular hole with a lamellar defect, presence of epiretinal proliferation. Surgical treatment for this will not be just something as an internal membrane peel. I usually like to peel the membrane and drape over the macular hole and tucking part of the internal limiting membrane into the hole to treat both macular hole and the lamellar defect. And therefore, you can see part of the internal limiting membrane clump, not only resolving the macular hole, but also the lamellar defect with reasonable visual outcome. So now we move into the intraretinal space, which is majority where the retinal conditions or macular pathologies occur. There are so many different conditions due to the time restrictions. We will briefly discuss some of them. And the most important point of this presentation is not that by the end you're able to make all these diagnoses, but rather be able to identify the regions of the pathology. And then you can generate a reasonable diagnosis and narrow down your differential. So let's take a look. One of my favorite conditions is macular hole, and I can give a whole talk on this topic itself. Now, macular hole is a clinical diagnosis. The Woski-Allen test is basically bringing the slit and make it really slim and over the macular hole, and as the patient is broken or not. If it's broken, then yeah, it's positive for the macular hole. We also have the red free and also the gold standard is OCT. Now, if we talk about macular hole, we have to pay respect to Dr. Gas, who previously, without OCT, was able to not only diagnose macular hole, but also be able to describe macular hole in such detail with only the use of slit lamp and indirect direct biometry. So he was able to just look at the macula and be able to diagnose the different stages. And something we can do, I certainly can do this, but fortunately I have access to OCT now. But nevertheless, this staging remains our universally accepted macular hole staging, especially amongst the retina community. So stage 1A is the contraction of the inner retina, leading to foveal pseudocyst. And clinically, you see this little dot. And stage 1B is the disruption of the ultraretinal, as we see on this OCT image. And both stage 1A, 1B spontaneously resolve in 50%. So no surgeries indicated, no observation is warranted. Now, in this case, this ultraretinal disturbance also has a name. And of course, there are many names, many signs. Some are actually useful. This is called subfoveal translucency. Essentially, what it means is that there's an ultraretinal defect. Sometimes, even after the repair of retinal detachment, vitreomacular traction, macular hole, you can still get this subfoveal translucency effect that with time may recover. So there we go. Stage 2 is a small macular hole that's of less than 400 microns and is associated with posterior hyaloid and with no also vitreous detachment. Stage 3 is, of course, large macular hole of more than 400 microns with no associated posterior vitreous detachment. And stage 4 is your large macular hole with PVD, which is a clinical diagnosis. So now, of course, in the era of OCT, we make our diagnosis and classification based on OCT images, which makes things a lot simpler. We have full thickness macular hole with or without vitreomacular traction. And we talk about either is it primary macular hole, so idiopathic, or is it secondary post-trauma, high myopia, myopia, and so on. And we define them as small, medium, or large macular hole. And of course, it's associated with responding treatments. For smaller macular holes with focal vitreomacular traction, treatment can include observation or pharmacological vitreolysis using upperclassmen. And also equally effective is pneumatic vitreolysis using C3F8 or SF6 expansile gas. Now, before we do any pneumatic PET/CT, which is something we do here at Toronto quite a lot, you have to thoroughly examine the peripheral retina to make sure there's no pathology. Otherwise, you can induce a wear tear detachment. And in the case of macular hole-induced foveal detachment or retinal detachment, I commonly place an intraretinal gas bubble, patient face down, and to allow the reattachment of the fovea and the macular hole before proceeding to surgery, making it much easier than trying to peel a detached retina, which is doable, but a bit more challenging. For larger macular holes or for vitreomacular adhesions that are broad, more than 1500 microns, surgery is warranted. Of course, the success of macular hole repair is fairly good. Even back in the days with simple vitrectomy, the holes usually close. However, there are less than 10% chance where the hole just simply doesn't close due to many reasons. And based on OCT, we're not only able to diagnose the macular hole, but we can also predict or sort of allow us a surgical planning. For example, keeping this very simple, the edge of the macular hole appears like a drawbridge. And if you imagine, this looks like a smaller macular hole that looked relatively fresh. And if you can imagine this drawbridge coming down, can achieve pretty good hole closure. Now, if you look at the picture below, this is a larger macular hole with what we call open. The hole is open and flat formation. So the edges of the retina, where the edges of the retina, has sort of stuck down to its new location. And for this the edges to come together pretty much require the lifting of the retina surface itself for it to reattach itself. And therefore, it's much harder and probably warrants a internal limiting membrane tug or autologous internal limiting membrane transplant or amniotic membrane or autologous retina transplant. So that's how we use the OCT image to plan for surgery. And I prefer calling the drawbridge or a broken bridge. So this is a patient, international patient who traveled to Canada. She had 3 surgeries, including the use of silicone oil. And of course, at this point, there is no intermediate to peel after 3 surgery. And so the decision was to use amniotic membrane. So post week 3 or 4, we can see that there is a very nice in situ amniotic membrane on this photo. And on OCT, we can see closure of macular hole with presence of amniotic membrane firmly stuck to the edges, just under the edges of the macular hole. With time, gliosis will occur and allow closure of the macular hole. So moving into the different layers of the retina, number 1 is nerve fiber layer. And we look at myelinated nerve fiber layer as an example. We all know myelination of nerve fiber layer is a congenital condition. Patients are usually asymptomatic. And the reason is because they had this, as a congenital condition that they're used to it. But on visual field, we know it corresponds with a sclerotoma. The reason is because on OCT, we can see myelination of nerve fiber layer. Myelin induces sort of hyperreflectivity, and it's certainly light blocking, as we can see these transmission defects, right? So there's blocking of the transmission, and that's why they don't see very well in that area. Similarly, with nerve fiber myelination of the fiber layer head, it's the same. You get this sort of thickening and hyperreflective band over the nerve fiber layer. Here's another example of nerve fiber layer whitening. What we see is hyaloid phase, which indicates that this patient is relatively young, with presence of these hyperreflective dots. Now we already know there's only a few conditions that results into these dots, and so it's either vitritis or it could be hemorrhage. There's sort of hyperreflectivity of nerve fiber layer associated with thickening of the fiber layer. And of course, there's because of the edema of nerve fiber layer, you get blocking of light and obscuration of ultraretinal images. So this is an image of a cotton wool spot in the context of a patient who presented with vitreous hemorrhage, cotton wool spot, retinal hemorrhage, and leukemic patient that mimicked the diagnosis of proliferative diabetic retinopathy. But what's important to highlight here is presence of cotton wool spot. Now, at any circumstances when you see cotton wool spots, the patient warrants a workup, because any cotton wool spots is abnormal, although there are idiopathic cases, but certainly warrants a case of screening for diabetes, hypertension, anemia, or your basic CBC. And for cases that are warranted or have potential history, try to rule out HIV, endocarditis, and of course, leukemia. Other conditions that cause nerve fiber layer edema and swelling is central retinal vein occlusion, ischemic type, and also central retinal artery occlusion. And now we talk about the varieties of macular edema. Either is secondary to diabetes, retinal vein occlusion, or it can be from uveitis, such as bird shots. Now, macular edema is a disruption of the inner blood retinal barrier, which is essentially the blood vessels, where the capillaries appear foveally, leading to accumulation of fluid in the intraretinal space, mainly in the inner nuclear, outer nuclear, with outer falciform layer. And of course, what is being leaked out is not simply just water, right? So what's being leaked out are usually plasma, which contains lipoproteins, albumin, cholesterol, and so on. And therefore, the consistency of the intraretinal fluid, the reflectivity, the edges between the different cysts can give us a prognosis or prognostic feature of the swelling. This is a slide I kept since I was a resident, and it remains very helpful for differential diagnosis of macular edema. It's called the prevalence. I'm sure there are different mnemonics, but it's certainly a good mnemonic to have, because macular edema is something that's very commonly, especially post-cataract surgery, retinal vein occlusion, use of certain medication, post-PRP, and so on. And of course, there's also another category called pseudo-macular edema. Right? So pseudo-CME are macular edema where appears to look like macular edema, but they do not leak on IVFA or fluorescein angiography. You see in the Vitreoretinal species called the fabric disease, certain type of RP, and then acid use for most top differentials. So let's take a look at how OCT can be a prognostic feature for many conditions. In this case, we're going to talk about diabetic macular edema. Of course, diabetic macular edema and its associated inflammatory process cytokines is a huge topic itself. But in this picture, you see the different varieties of diabetic macular edema and the different sizes of the cysts. So if we just look at the picture and call it macular edema, we're missing a lot more information. The size of the intraretinal cyst, more than 200 microns, the location of the cyst, the orientation, the structures adjacent to the cyst, the content in the cyst, presence of microaneurysms that are present adjacent to the cyst, hyperreflective foci, the abnormality of diabetic vitreal, diabetic choroid pathology, all plays a role in the outcome of this patient outcome and response to treatments. So this is a condition that we see in diabetes and also retinal vein occlusions and anivascular leakage conditions called the plume sign, with the intracystic cavity hyperreflective material. What it signifies is a severe disruption of the retinal vasculature leading to leakage of proteinaceous material. And of course, you can imagine the treatment might be a little bit more resistant and we warrant not just anti-VEGF, but also potentially the use of steroids. Here we see the columns between this system of macular edema. So in this case, the columns between the cysts are considered to be either Mueller cells or bipolar cells. And that's why for many patients with sort of that DME, their vision remains good because the connection and the transmission of signal is still present. Of course, as you can imagine, the larger the size of the cyst, the more stretched and the more chronic it is, then you're going to over time damage these microstructures. When there is loss of these sort of bridging septae with fusion of these giant cysts, then the visual outcome and response to treatment is significantly sort of sterile, right? And at the same time, when there's a larger retinal cyst in the context of DME, sometimes it can mean macular ischemia. Hyperreflective foci in the context of DME and vascular leakage signifies these sort of protein materials being secreted or being released from breakdown of in-brain blood retinal barrier. And they are thought to be precursors to hard exudates, which are not something you want to see close to the fovea as you see in these patients. Now, the yellow box highlights the presence of hyperreflective foci, and the green arrow points to hard exudates. And of course, both are very close and they're parafoveally. And as we can see, these cottonwool spots are light blocking because they're cholesterol content. And as a solid particle, it blocks light. So when these particles comes to within the fovea region, it will cause patients to have significant vision loss. Another good OCT biomarker or prognostic marker for visual outcome is this organization of the retinal inner layers. We can use this not only in diabetic macular edema, but also retinal vein occlusion and so on. Essentially, what it means is that you look at the layers of retina. Say a patient presents with macular edema, in this case, diabetic macular edema. Someone asked the question, what's the difference between diabetic macular edema and macular edema of retinal vein occlusion or uveitis? Usually, the simple answer is the macular edema looks a bit dirty. And the reason is because for diabetes, you're leaking not only fluid, but protein material. Also, there's presence of hard exudate and presence of microaneurysms. So the entire picture doesn't look clean. And whereas I'll go back to a picture of macular edema secondary to retinal vein occlusion, as we see in this top right hand corner. You see the picture is very clean with clean hollow cysts. And these are usually macular edema secondary to retinal vein occlusion and inflammatory process. Whereas you look at the pictures of macular edema from diabetes, there's always something in there and the fluid is not as clean. So that's just a sort of a simple way of looking at it for myself, at least. And so what does this organization of the inner retina layer mean? Well, it basically means, are you able to decipher the different layers or different layers of the inner retina? So here, the yellow line delineates nerve fiber layer, ganglion cell layer, inner plexiform layer, and inner nuclear layer. So when these layers are still present, you predict that visual outcome should be good with the treatment. And of course, vision is 20/30, and you can see preserved inner layers of the retina. Whereas in this patient who had chronic macular edema, including having to treat it with a vitrectomy surgery, the yellow box highlights reattached retina here with no macular edema, but diffusely uniform and homogeneous inconsistency that you can't really isolate the different layers. And this is the loss of retinal layers, and therefore is a prognosis for visual acuity. And of course, this patient with chronic macular edema has macular ischemia. So how does this picture compare to the macular edemas that we've seen previously? You see, these are not all oval in shape, but rather you have these vertical bridging columns. And this is a feature of a condition called retinoschisis. The yellow arrow points to inner retinoschisis, which is less common, and they occur in the layer of the fiber layer. The ultra-retinoschisis occur at the ultra-plexiform layer, and usually patients have very good vision. And the reason is because, just like what we discussed for DME, the connection is still there, except that the layer sort of split a bit, causing a bit of stretching of the Mueller cells and bipolar cells. But the transmission of signal is still present. Foveal schisis, aside from X-linked juvenile foveal schisis, one of the most common cause is myopia, and it's thought to be due to mechanical stretching and elongation of the globe, leading to some stretching and splitting of the retinal layers. So the bridging column is one of the features of retinoschisis, and you can see some other examples of retinoschisis. They all look the same, and these are a lot of the OCT interpretations are basically pattern recognitions. And if you recognize one, sometimes you will be able to recognize different presentations. So let's put this all together, what we just talked about. This is a patient of 44-year-old age, Asian female, presenting with bilaterally a picture like this. Her vision's down to 2200. So what do we see here? First of all, we see presence of sort of concavity here with thinning of the choroid in keeping with a high myopic patient with posterior staphyloma. Now, what we see here is macular or vitreoretinal traction, labeled by the green arrow, presence of epiretinal membrane causing corrugation on retinal surface, intraretinal fluid over the fovea, presence of altered retinoschisis, inner retinoschisis, and as you compare the red arrow to the green arrow, you do not want to initiate your membrane peeling over the red arrow, because this is normal tissue, but with retinoschisis of the nerve fiber layer. You do not want to rip or disturb the retinal layer, retinal nerve fiber layer. And of course, there's subretinal fluid associated with foveal detachment in the case of myopic maculopathy. Like we discussed, there's thinning of the choroid, which is associated with high myopia and staphyloma. And we can also see this hypertransmission. And the reason you have this hypertransmission is because of myopic maculopathy with loss of RPE. And when you have loss of RPE tissue, then light penetrates better. So that also gives you a visual prognostic feature that even after surgery, vision will not be 20/20 or close to 20/20 because of myopic macular degeneration. So this patient undergone bilateral vitrectomy with a limiting membrane peel from edges of the staphyloma to edge of staphyloma in these cases of myopia patient. And you can see that what we discussed previously, there's on the fundus picture here, you can see myopic degeneration with RPE loss. So after a month post-surgery, there are residual subretinal fluid and schisis, and patient remains symptomatic. So instead of repeating the surgery, I injected SF6 gas bubble or expansile gas bubble and allow patient face down. And after a month, patient vision returned to near baseline, of course, limited by presence of RPE loss secondary to myopic neuropathy. So it goes to highlight that your understanding of the OCT images actually not only help you make the diagnosis, but also predict the visual outcome for patients. Now, someone asked, what's the difference between retinoschisis versus retinal detachment? Well, schisis is splitting of the layer of retina, but the retina, outer retina, is still intact. Whereas retinal detachment is the detachment of the entire neurosensory retina. The difference clinically is that retinoschisis are usually dome-shaped, as you see in this image at the bottom right, and they're more transparent, less mobile, no corrugation on the surface, and less likely to induce RPE atrophy. And of course, one of the simple way to test it is if you're concerned about peripheral retinal detachment, a laser uptake indicates that it is retinoschisis because the retina is still attached. Whereas the laser retinopexy treatment for retinal detachment, there is no uptake because the retina is detached, much like a wallpaper coming off the wall. And if you want to put a pin over it, it won't stick down to the wall itself. Whereas schisis is still attached to the wall because the outer layer is still attached. However, the best way to differentiate them, if you can, is still using OCT. Whereas subretinal fluid or retinal detachment looks something like this, with detachments of neurosensory retina and presence of subretinal fluid and intact RPE layer. So this is a patient that was sent for repeat treatment of macular degeneration, which she had stopped many years ago. She had a history of macular degeneration, received treatment, and anti-VEGF treatment was stopped 3 years ago. So she was referred for intraretinal fluid and possible repeat treatment. You can see that vitreous cavity is clear. The epiretinal surface or vitreomacular interface is normal. Intraretinally, you see this sort of cystic look appearing structure with hyper-reflective lining and hyporeflective lumen, overlaying this sort of area of atrophy or subretinal fibrosis. So what can this be? Do you proceed with treatment? Of course, you already know on the picture that this is an area of atrophy with degeneration. Now, what this small structure is outer retinal tubulation. What outer retinal tubulation is, they're essentially a breakdown of photoreceptor outer segments. So this can happen in any condition that has chronic macular degenerative process, including AMD, Stargardt's disease, where the RPE is lost. And so without the RPE, the photoreceptors do not get their proper nutrition and elimination of the waste product. And as a result, they start to break down. The outer segment of photoreceptor is hydrophobic, just like putting a drop of oil in water. It likes to protect itself and wrap itself into a ring, and therefore forming these outer retinal tubulations. This is simply different than retinal cyst, which means you don't treat them. Even if you repeatedly inject these patients, they will still be there. In fact, in the context of a subretinal fibrosis with outer retinal tubulation, and in the absence of any intraretinal fluid, subretinal fluid or retinal hemorrhage, you can consider BC treatments or extend treatments for longer time periods. So here's another interesting case of 77-year female presenting with acute loss of persistent paracentral scotoma. And again, you see is something that's in the middle part of the macula here. What we see is this hyper-reflective band. Of course, vision's 20/40. Overall, she's seeing quite well, but she complains of paracentral scotoma, which is a dark shadow right in the center of the left eye. And the red arrow labels this hyper-reflective band that we see. And it is quite a pathognomonic for a certain condition. On this photo, you may or may not see this grayish little segment parafoveally. And this condition happens in the middle layer of the retina. And therefore, what do you think this is called? As most of the conditions are similar, with sort of this hyper-reflective band occurring in the middle layer of the retina. Now, if we look back, we remember that for cotton wool spots, when their fiber ischemia also give you this white band, right? Like sort of white hyper-reflective thickness of the nerve fiber layer. So this is a condition called paracentral acute middle maculopathy, or ischemia of the middle retina. It is usually associated with infarction of the macular capillaries, mainly in the middle layer, and the reason is because of capillaries in the middle layer of the retina has these watershed zone. So watershed zone means they don't get their perfusion, but rather they get perfusion from inner outer retina. And when there is focal ischemia or decrease in blood supply, especially with risk factors such as using vasopressors, caffeine, diabetes, or vascular disease, you can get these ischemias. Often they can also be associated with central retinal artery occlusion or central retinal vein occlusion. Another very key way to sort of help you diagnose patients' vision is the use of a very important structure called the ISOS, or the ellipsoid zone. And this zone is important because it is the powerhouse of the photoreceptor, and it contains a lot of mitochondria that's required for photoreceptors. A disturbance of this layer will result in a decrease in vision. As we will see in this case, a 45-year-old gentleman who came from Barbados complained that he's had many years of just sort of poor vision, and you can see on OCT there's bilateral disruption of the outer retinal layer and disruption of the ellipsoid layer, causing some transmission, sort of a hypertransmission. And then this photo shows a sort of little yellow dot. So, what's your differential diagnosis? Of course, the most common one being solar maculopathy, right? This is the one that most of us sort of familiar with, where someone looked at the sun, either the sun directly, even if you wear your sunglasses, staring at eclipse, and eclipse is not safe, and it can often result in photic maculopathy. So this includes solar maculopathy, or even laser maculopathy, so laser pointer induced maculopathy, which we see sometimes. And of course, what we did previously discuss about subfoveal translucency, as you see in the bottom image. This is post-VMT macular whole retinal detachment repair. You can get this sort of autoretinal defect. And some of the newer diagnoses are pauper maculopathy with the use of nitrate content for recreational use, tamoxifen, pseudopatelliform, adult vitelliform dystrophy, and unilateral acute idiopathic maculopathy. For focal foveolitis, you can also get this sort of disruption of the ellipsoid layer. However, if you really scrutinize the OCT images of patients, you will see the subtle differences between the inflammatory part, different defects, and defects are caused by detachment of vitreomacular function. The sort of the inflammatory process usually have a little bit of fluff to it, much like your freshly diagnosed laser pointer-induced maculopathy. You get this hyper-reflectivity in the subfoveal region. And similarly with uveitis, you can get this sort of pitchfork sign where there's this sort of fluff right over your outer retina. And that differentiates, these subtleties differentiates, will give you a better differential diagnosis. Another good use of the ellipsoid layer where the ISOS junction is vision prediction. For example, this patient presents with diffuse confluent drusen with somewhat the sort of hyper-reflective activated RPE. You would imagine that this patient might not see that well, but let's look at the ellipsoid layer. The ellipsoid layer is intact, and therefore patient's vision is 20/50. You can still see very well, especially over the fovea. And here's another patient with focal geographic atrophy. Vision is not going to be great. You can see there's hypertransmission results from loss of RPE. So let's follow the ellipsoid layer. You also see there's an abrupt termination of the ellipsoid layer with loss of RPE, and therefore vision is not great unless we expect the counting finger vision. So let's move on to the subretinal space, and we'll start with a case instead of going over the different images. So a 75-year-old Caucasian female referred for dry macular degeneration both eyes. She's otherwise healthy on high blood pressure medication. Vision's 20/30. She's not so much disturbed by her vision, but our colleague have noticed these sort of yellow flecks over her macula. Similarly, on the right eye, you also get these sort of yellow flecks. On autofluorescence, you see these yellow flecks becomes hypo-autofluorescence. And of course, we're going to scrutinize our OCT. Now, what do we see? You see these sort of hyper-reflective sort of little bumps. Is it above or below the RPE? So we can see that these hyper-reflective bumps are above RPE. So what does this mean? I mean, you can call these drusen, right? But drusens are usually subretinal, no? So these are little sort of deposits that's just laying underneath the ellipsoid layer and above the RPE. So what's the diagnosis? We are no longer happy or satisfied with the diagnosis of just drusen, because that's just a general term. We need to differentiate. Is it soft, hard drusen, confluent drusen, large drusen? Is it calcific drusen that can lead to geographic atrophy? Is it your colloidal drusen? Is it your pachychoroid drusen? Is it cuticular drusen? Is it your reticular pseudodrusen? Of course, the answer in this case, like I said, all drusens are sub-RPE. And in this case, the deposit is above RPE, therefore this is reticular pseudodrusen. Why is this important? Because each of the drusen has its own diagnosis and potential implications. So for pseudodrusen, much than what we already discussed, it's little deposit that lies between RPE and ellipsoid layer. Therefore, you can imagine it disrupts the connection between photoreceptor and RPE, leading to atrophy and most commonly type 3 CMBM, RAP lesions. An 88-year-old Caucasian female presents with increase of blurry vision on the right side of 2100 vision. So on OCT, we see that on the right eye, there is presence of subretinal fluid in the region of macular papular bundle, and same thing on the retina thickness map, and associated with subretinal hyperreflective material. So many of you expressed interest in learning about OCT angiography, and that in itself is a big talk. And the most useful aspect of OCT angiography is in the context of neovascularization. So in this case, we're not 100% certain if the subretinal fluid is due to loss of RPE failure. So when the RPE becomes defective, you can often get subretinal fluid without the absence of choroidal neovascularization. And this is when OCT angiography comes into play. You can see that there's this sort of vascular net. And also you can see these red spots. The red spots is flow signal, meaning these are true flow signals in this vascular net. And therefore this is choroidal neovascularization type 1, resulting in presence of subretinal fluid. And so this patient warrants anti-VEGF treatments. She received 3 injections and vision restored 20/50 as this membrane just sort of affected her subfoveal area. And with repeated injection, you can see this vascular net shrink in size with resolution of subretinal fluid. However, like what we just said, choroidal neovascularization and presence of retinal fluid with imaging modality is now becoming more complicated than your dry and wet AMD. As we can see, there are non-neovascular, non-exudative, or your dry AMD. I use the serous PAD in this case, but of course, drusenoid PAD will. Then we have the non-neovascular exudative AMD, in which case you see no neovascularization or presence of subretinal fluid. And this is usually due to your RPE failure. So despite repeated injections, you may or may not dissolve the subretinal fluid. In fact, based on the fluid study, that sometimes subretinal fluid is healthy, just like in central serous chorioretinopathy or CSR. Fluid might be, protective for these cases. As you are too aggressive, can lead to atrophy and collapse of the residuals from the RPE layer there. Then you have your choroidal neovascular membrane with exudate. And this is your wet AMD. And of course, there's presence of neovascular membrane without any leakage. And so this also warrants further investigation on what we should do. Other important signs and prognostic features associated with wet AMD includes the onion sign, prechoroidal cleft, as you see between the red arrows, neurodegenerative cysts, RPE rip, altered retinal tubulation, and shallow irregular RPE elevation, sire or double layer sign. So due to time, we'll describe a few. First, we see this sort of choroidal neovascularization with presence of fibrovascular PED with this sort of onion sign. You can see the layers of onion. And this basically indicates a chronic exudative process where the layering of cholesterol give you this sort of layering of sort of image pattern. And it's usually found in type 1 CMVM and PCB. So despite repeated anti-VEGF treatment, this layer will be there. But in essence, if you see that, it means that this patient had choroidal neovascular membrane with presence of cholesterol deposit. How about in this case? We see that there's the OCT of the macula with presence of subretinal hyperreflective material, presence of a type 1 choroidal neovascular membrane with onion sign, and what the arrow is pointing at are pre-choroidal cleft. So you can see the choroid, and these clefts are in between the RPE Brooks membrane and the choroid, therefore it's called pre-choroidal cleft. The significance of this is that in order to create these clefts, there must be some sort of contraction or fibrosis in this macular membrane. And this contraction causes little focal detachments of your choroidal neovascular membrane, or RPE, and underlying Brooks membrane. So what happens is there's 50% chance of associated RPE rip and subretinal hemorrhage, something you should warn the patient before treatment. As in this case, this is a patient I saw who presented with choroidal neovascularization with this large pre-choroidal cleft, signaling that there is significant tension with fibrosis. And patient received anti-VEGF treatment, and of course, there's RPE rip. These signs will give you the prognosis and some of the features that you have to warn patient beforehand. So these things do happen. And we have these sort of intraretinal little oval-shaped cysts. These are not macular edema because if you look at the retina, it's not swollen. The size of retinal layer seems to be pretty consistent, if not little atrophic. And on the retinal thickness map, there's no thickening. So these are degenerative cysts, usually associated with chronic macular edema or associated with neurodegenerative disease, sometimes in very advanced glaucoma or optic neuropathies. You can also see these degenerative cysts. And the significance of this is that they're not edema, and therefore treatment will not work. So when we put this all together, we have these sort of retinal pseudocysts where it basically don't warrant any intravitreal anti-VEGF treatments. The ultraretinal tubulation on the left, the degenerative cyst in the middle, and also the sort of squarish cavity pattern of macular telangiectasia are retinal pseudocysts that usually does not warrant anti-VEGF or steroid treatments. The feature of MacTel, just didn't have the time to go over it. It also has this key feature. It's got the pathognomonic high internal limiting membrane draping. So you see this very thin layer of internal limiting membrane. And you have this sort of square or trapezoidal pattern of intraretinal cystic cavity. And so these are not fluid, but rather neurodegenerative loss of tissues secondary to the phalangotic vessels temporally to the fovea. And finally, we enter the choroidal zone. Previously, we don't know too much about the choroid, and now there are various conditions of the choroidal disease, and we'll briefly discuss a few. The choroid is a very important structure that contains 5 different layers, and its function is to supply the retina and modulate, sort of support the retina function. It is very important. And as we can see in the context of high myopic patients, they usually get elongation of their globe and leading to axial myopia. And associated with this is thinning of the choroid, as we see with the red arrow. And as the choroid and the choriocapillaris gets thinner, then there's a lack of support to the RPE and eventually leading to myopic degeneration. Another very common condition that sometimes we see associated with high myopic patients is this big bulge, almost like a dome shape, right? that sort of forms within the posterior staphyloma. And this is termed dome-shaped maculopathy. Its significance is that it's sometimes associated with subretinal fluid similar to CSR, that it often is harder to treat and more persistent. So when we see staphyloma or high myopic patients, you can see this resistant area over the fovea. So instead of bulging out like the rest of the staphyloma, the parafoveal area seems to have a bit of resistance to bulge outward that form the staphyloma, and therefore forming this sort of dome-shaped appearance. And that's called dome-shaped maculopathy. So based on what we've learned just now, we looked at an 87-year-old male referred for macular degeneration. He's complaining his vision has been declining over the past 5 years. When we look, we don't really appreciate a whole lot of drusens, and there's really no sign of macular degeneration, but rather very tessellated fundus where we can very clearly visualize the choroidal vessels. And on OCT, the retinal layers look pretty normal, but significant is the thinning of the choroid in the absence of any pathology. So this is a condition known as age-related choroidal atrophy, and it is associated with age, of course, in the absence of drusen, and it is thought to be due to age-related choroidal sclerosis. And they're also at higher risk of developing glaucoma and macular degeneration. Now, CSR is another condition of choroid spectrum disease, and we all know one of the features of central serous is a thick pachychoroid vessels, leading to a small serous PUD associated with subretinal fluid. And of course, there's these brush border patterns of elongated photoreceptor outer segments. These are the features of CSR OCT. And of course, a fundus fluorescence, you can see the draping sign where the fluid drapes with gravity and forming this hyporeflectivity autofluorescence. And on IVFA, this is the small stack sign, and the other ones are expansile duct and the diffuse pattern. Differential diagnosis of CSR, as some of you requested, includes neovascularization, also optic pit. So anytime you see subretinal fluid, always trace that fluid nasally to make sure there's no optic pit. And other conditions are malignant hypertension, uveal effusion syndrome, posterior scleritis, and choroidal tumors of various kinds. Here's a very young patient of 25 years of age, asymptomatic, referred for a RPE defect over the right eye. We can see there's a little bit of RPE changes. But his vision is 20/25. He's not bothered with the tilted disc. And on OCT, we see this sort of outpouching of the RPE layer with intact retina, and the retina seems to conform to this outpouching. So what can this be? Now, what is the diagnosis of this sort of outpouching of the RPE? And this is a condition called choroidal excavation. So we can see this excavation of the choroid leading to outpouching of the RPE. There are two types. One is the non-conforming type, where the retina does not conform to the outpouching. And then there's the conforming type, where the outer retina conforms to the outer retina. Outer retina sort of outgoing. And this condition is associated with CSR and also choroidal neovascularization. So when we see this, patients should be alerted for potential CSR and choroidal neovascularization. Traditionally, it was thought that this may be congenital, but recently there are publications that this has been acquired, as I have a few cases of acquired choroidal excavation. Again, this is CSR with presence of subretinal fluid, and enhanced depth imaging will confirm pachychoroid. What pachychoroid means, they're pachy vessels. The hollow vessels are large, and also the choroid is thick. Normally, the choroid should be around the thickness of the retina. In pachychoroid spectrum disease, the choroid is much thicker with much larger hollow vessel with outer choroidal vessels than usual. So this brings us to the new sort of spectrum condition called the pachychoroid spectrum disorder. And we have CSR PCV, and peripapular pachychoroid syndrome, and also pachydrusen and pachychoroid-related RPE changes. So these are the different categories or subtypes of pachychoroid spectrum disease. And the thought process behind this is that your enlarged Hauler vessels is compressing on the settlers and the choriocapillaris, leading to defect choriocapillaris vessel and resulting in RPE changes. And that leads to formation of small drusen's, and then CSR, and then choroidal revascularization, PCV, and so on. And so we can see these pachy vessels as labeled by the blue arrow. These are large Hauler's vessel, and as the vessel gets larger, it compresses on the inner choroid vessels, like the settlers and choriocapillaris. And over time, because of disruption of choriocapillaris, you get RPE defect, and subsequently all the other following conditions. And of course, in the choroid, don't forget about choroidal mass lesions. Your hemangiomas, your tumors, your choroidal nevus, and also choroidal calcification for those who are interested. So at the end of the day, we can't make the confirmed 100% diagnosis in all cases, but certainly if you divide into zones, you can significantly narrow down your differential diagnosis. And also, it's very fun to have these images and be able to tell the subtle differences of the findings on OCT. And of course, many people ask, what else do you use in retina? In addition to OCT angiography, we have optos, autofluorescence, IVFA, ICG, and B-scan. And so it's really a great time that we have access to all these imaging modalities that help us to make the diagnosis of different conditions. Some people ask about how do you make diagnosis of retinal dystrophies? Well, often dystrophies, by the time they present, they already presented with significant atrophy, and therefore you will need multimodal imaging. And use of multimodal imaging or involve the use of fluorescence, IVFA, OCTA, OCT, multifocal ERG electrophysiology. So let's go back to our post-lecture quiz and see if you can name all the conditions. So number one, pseudo-hole. Most of you sort of during the pre-lecture quiz already scored quite well. So let's do this again. Which of the following is pseudo-hole? Yes, so the answer is 2. So well, I will finish the next one before we give the answers. And the answer is number 2. And which of the following is retinal schisis or contain retinal schisis? So the answer is 3. That's correct. So let's go through them. Number 1 is vitreomacular traction leading to a full thickness macular hole with presence of intraretinal cystic cavity. Number 2 is epiretinal membrane associated with parafoveal thickening and your pseudo hole, right? So straight left edge. Number 3 is your posterior staphyloma with foveal detachment, full thickness macular hole, presence of retinal schisis. And number 4 is your lamellar hole that looks like an anvil, right? With presence of epiretinal proliferation. And so in this picture, due to a time constraint, why don't I just go over the answer with everyone? So the proper description of this is presence of vitreoretinal traction, as you can see on this, sort of follow my cursor here. Presence of epiretinal membrane. And these vertical columns that we discussed are foveal schisis, right? So there's no intraretinal fluid in this case. So this will be, the answer is 5, 1, 2, and 3 without macular edema. And reticular pseudodrusen, as we discussed, number 1 is cuticular drusen, because the drusen is sub-RPE. You can see our little RPE elevations, and these look like little stall tooths, right? They look like little tooth. So, and they're of uniform triangular formation. So these are cuticular drusens. 3 is your soft and hard drusens. And then, 3 is your colloidal drusens. 4 is your pachydrusen, associated pachychoroid. And usually these are isolated drusens. And 5 is your confluent soft drusens. And this, of course, with outpouching of the RPE, is choroidal excavation, which is associated with choroidal neovascularization and CSR. So I hope you enjoyed, and I did go over time. I apologize. But for those who are interested, OCT cases, and I hope you can also contribute your cases. I know there are some questions that just due to time, I'll just answer one or two of them. Do you recommend swept source or spectral domain? Well, if you're looking for detail, whichever image give you better detail swept source, of course, it's better. There's also way better imaging modalities now with Silverstone, where you can combine optos and OCT and be able to drag where you want to sort of scan over the sort of optos map. So it's really quite interesting. Should we avoid intravitreal injection if we see prechoroidal cleft? I mean, if there's active CNVM with subretinal hemorrhage, you still proceed with treatment. But like I said, treatment is not wrong if you alert patient with potential complications, just like surgery. I mean, just because potential infection, retinal detachment, pain can occur does not mean you don't proceed with treatment, but you have to inform them of the proper sort of potential prognosis. Let's see. How do you treat acute photic maculopathy? Well, I don't think there's a proper treatment for acute photic maculopathy, but there are multiple studies that suggest use of steroid. I have a few patients where they were injured by a laser pointer. And one very sad case where the patient's a construction worker. He was using a laser leveling device to level some stuff to hang on the wall. And the battery is to put in like a flashlight. You can imagine you stuck the battery in and you're pointing the laser right in your face. So as he's clicking the battery into place, the laser light shone right into his eye and resulted in a focal sort of hyper-reflectivity over the fovea. No treatments offered. His vision was 20/20, very sharp vision, and he presented 20/60. Over time, it still resolved with 20/25 vision. However, post-photic injuries, you can result in CNVM, macular holes, epiretinal membrane. So warrants observation. For really bad ones or really acute, consider, steroid if that's the only thing that's sort of published. But again, you really need a large sort of study to do this. So I think that's pretty much it. I'm sorry I can't stay very long. I have to attend to clinic. And thanks, Lawrence, again for inviting me for this presentation.